Okay, I think we are live, and sometimes it takes for a few seconds. Okay, hi everyone. I hope that everyone can see us and hear us. I'm just waiting for some hi in the chat box. Okay, everyone hear us? Okay, perfect. Great. So we had one hi from Jeremy. Okay, perfect. We have everyone here. I'm so happy to introduce our very own Dr. Tawfiq Valiante as the speaker for a neuromodulation session. Tawfiq graduated from MD PhD program at U of T. He became fellow of the Royal College of Physicians and Surgeons of Canada, and then he pursued an epilepsy neurosurgery fellowship at the University of Washington, Seattle. Tawfiq is a scientist at the Cranberry Research Institute, University Health Network. He's a staff neurosurgeon at Toronto Western Hospital and a surgical director epilepsy program at Toronto Western Hospital and an associate professor of surgery, Faculty of Medicine, U of T. And his research is on clinical neuroscience, computational neuroscience, neurotechnology, and to be honest with you, he's doing everything you think. And thank you so much for your time. I know that you had surgery today. Anyways, I'm going to focus. Okay, so it's actually already focused. Please go ahead.
Okay, thank you very much, Milad. Thanks so much to the organizing committee. Big shout out to Scott Rich for pushing this forward as well. So it's a pleasure to be here. I'm basically a messenger. I'm going to talk about really all the great work that other people are doing, but I'm very, very fortunate to be part of. I want to put a bit of a plug in for Canada. I understand that all continents are represented, and a plug in for CRANIA, the Center for Advancing Neurotechnological Innovation and Application, which is within sort of the sphere or intellectual sphere, which a lot of this work is being done. So for those of you who are not, for those of you who may not be familiar with epilepsy, I'm going to put my advocate hat on and tell you a little bit about it. But it's considered the most common serious neurological disorder in the world. It affects about 1% of the population, a little bit less in developed countries. It's really a prototype of a chronic neurological condition affecting people within all spheres of their existence. In fact, if you look at various quality of life metrics, people with epilepsy have the lowest self-reported quality of life amongst all chronic conditions. So as a clinician, I'm very motivated to help those individuals with epilepsy, particularly in regards to their quality of life. And it's really a multi-pronged approach. And I'd like to kind of contextualize all the work we do in the lab within neuromodulation. So I want to put a little plug in for a recent study led by Marjan Rafi that was just published, looking at how music may be potential therapy, very powerful neuromodulator for helping individuals manage their difficult to control seizures. Another form of neuromodulation, which is another very, very powerful non-invasive approach, is social activism. It's prescribe it all the time for the students in my lab, and my lab's very involved in this as well. And I think, as we see things unfold in the world, it's there's no shortage of the things that we can advocate for and champion. So in the context of neuromodulation and epilepsy, about 70% of patients are relatively well controlled on medication, leaving about 30 patients who require some sort of alternate to medication. About half of this, the remainder of 30% who are medically refractory and not responding to medications are potential surgical candidates, and they're the common patients that I operate on specifically specifically perform resective procedures, which is really removal of an area of the brain that generates seizures. The other 15% are then left without any significant alternatives, and there are a number of adjunctive treatments come in, not the least of which I mentioned a few already, as well as ketogenic diet is another important component of their care. But neuromodulation neurostimulators is really an emerging or increasingly interesting opportunity, and there's been good clinical data that supports neuromodulation in epilepsy. The general idea is that if we can identify when a seizure is going to occur, then potentially we could stimulate the brain and stop a seizure. And so, really, one of the holy grails in epilepsy research, at least from my perspective, is really creating that kind of device that might be able to do that. However, the idea of a closed loop device which both senses can can sense, decode, and stimulate meaningfully to stop a seizure or abort a seizure, preempt a seizure, is not really necessarily a new concept, and also permeates other neurosurgical and neurological concepts. For example, Parkinson's disease, another active area of research around closed loop implementations, and increasingly memory, as we see an increasing number of studies looking at the potential positive effects of electrical stimulation in the brain. So clinically, we really have right now really only electricity as our only modality to both sense brain activity and to stimulate it. And currently, there are two devices that are closed loop. One is called the NeuroPace, and the other is the Sentiva, or the newest version of the vagus nerve stimulator, Sentiva. The NeuroPace device is really kind of how one conceptualizes closed loop. It does active sensing, so it's sensing electrical activity. It's computing some aspects of it, relatively simple aspects of those signals, and then stimulating to try to abort seizures. This is not to put either of these devices down. However, it's a very difficult problem, and we do know from the data that this device generates about 2,000 false stimulations per day. Very few people, if any, are rendered seizure-free. So we amongst others are interested in potentially trying to improve upon the availability of this kind of the efficacy of this type of technology. The one thing which I put in a little bit of a Canadian context is that, in fact, we do not have the NeuroPace available to us in Canada, and thus Canadians don't have access to a closed-loop device. So I'm going to talk a little bit about the work that we do in regards to hardware development. This is work really led by Gerard O'Leary, who's a PhD student, and collaborators at Electrical and Computer Engineering here at University of Toronto and at Princeton. And basically, what I love about this area of research is which is that there's a lot of efforts to decode brain activity and sort of meaningfully understand what brain state one is in at any given moment, and that can be done offline. But I think one of the cool things about this area is really trying to create hardware implementations of these types of approaches, because we do want to make devices that we can implant and that operate in real time. And we have also, there's always a really nice partnership between our engineering colleagues and our neurophysiology, neurobiological teams. So not to belabor the point, but the current devices are relatively simplistic in the kind of things that they detect, and the number of, and they have in general a paucity of channels. We are, just like others, enamored by the idea of scale, and the idea that the more electrodes, the better. The more features you can identify, the better. Whether or not that ultimately will be the panacea in this whole area of closed loop technology, we're not sure, but we are pursuing that. And so, in fact, we've developed two pieces of hardware. One I'll talk about today, which is called NeurIP, which is certainly a step above in the context of the number of channels, the number of features it can look at. It can look at bivariate measures, and a new version of the chip, which is called BrainForest, which I won't talk about today, but is based on a neuromorphic architecture. So NeurIP is basically a device that does signal processing and brain state classification. Its unique features are that it has an upfront autoencoder for dimensionality reduction to reduce the amount of power consumption for the various computations, and signal processing as one would expect. Features abstractor, one of the unique aspects of this chip is that in real time it can perform bivariate measures as well as more complex measures on univariate measures like cross-frequency coupling. It does have a stimulator, which is an arbitrary waveform generators, and all the stimulating sites can be stimulated independently. And one of the unique aspects of this, which is that typically when one is doing feature detection, one is limited to that point in time where you're actually estimating these features, and so recognizing the sort of scale-free dynamics of the brain and the long time scale correlations, we've implemented a memory component to it, such that the features at one moment in time also reflect the past history of the system. Classifying seizure versus non-seizure states is very difficult given the limited training data that we get, and so we've taken basically an outlier approach where we've trained our classifiers on interictal data, which is the data between seizures, and then to recognize everything outside of that as being an anomaly in a seizure. This is just an example of the output of the system versus clinical determination of the seizure onset. As you can see, there's no shortage of features that we can compute, and this brings us to a problem, which is just ideally, what is the ideal feature set? And so we're actively exploring ways of accelerating our ability to do the offline training, because this can get very computationally intensive. With all that, our ultimate goal was in fact to run a clinical trial, which we've undertaken and we're continuing, where in fact in real time NeurIP sits within this system and basically does its thing. However, we've certainly realized that acute clinical trials for this type of approach is fraught with a number of problems, not the least of which is that we have a very short period of time with individuals in the epilepsy monitoring unit, and thus we're extremely motivated, in fact, to develop our own devices, as we don't have access to either the NeuroPace or research platform type device like the that provided by Medtronic. If detection is a difficult problem, then stimulation represents another very significant problem, as we have no really principled approaches to stimulating the brain and modulating brain activity, and we've often done this in a blind fashion. And so we're interested in trying to exploit the hardware that we have, where we can do multi-site stimulation. And when we start to approach this in biological systems, we ran into a significant bottleneck, since these systems were very inflexible and were unable to basically recapitulate the abilities that we're developing in hardware. And so we have the opportunity to study cortical slices as well as human cortical slices. And we wanted to implement this type of neural interface where basically it would have all the capabilities of the hardware that we're developing, where we could truly test stimulation paradigms within this within the multi-electrode array environment. And so this was our first iteration of the system, where we would basically recapitulate the hardware that was designed on an FPGA. We've, however, since upgraded that to now a system which is extensible, so you can have many hundreds of channels, as many as you want, really. However, one of the really cool things about this system is that we can take now the chips that are being developed and basically plug them into this PCB here, and now we have really a test bed, a biological and computational test bed for both the chip and the biological system. And the last thing I just wanted to touch upon is the other kind of work that we're doing in the lab here, which are sort of biologically inspired models. And this is also borne out by the problem, which is that how do you actually develop principled approaches to stimulation? And I think, you know, we're starting to see how computational models can be helpful through work, the Gerside group and virtual brain type of work. And in my lab, we have the unique opportunity to actually study human cortical tissue. And so we have kind of this ethos, which is that to create human brain models to study, then we really need to investigate human physiology. And so this is some work that's being done by Homaira Moradi, who's a scientific associate in my lab, who's done a very extensive characterization of human cortical neurons across the cortical layers. And I just want to link this to the work that we're doing now in collaboration on the computational side with Francis Skinner and Scott, where we've taken our data, and Scott has been able to infer very specific properties of specific ion channels using the electrophysiological data. And, you know, with that, we're actually very hopeful that we can start to characterize human phenomenon, for example, some of the unique features that human cortical tissue displays and some of the unique electrophysiological signatures that human brain displays by creating these computational models, with a view that ultimately maybe we're able then to be inspired towards more human-directed neuromodulation strategies. Additionally, we also study non-human or rodent tissue, and this is another example of where we're trying to use our biological data towards an ultimate goal, although, you know, a long way to get there, towards neuromodulation. So we've actually been able, we've shown that in fact interneurons can be complicit in the initiation of seizures. However, this was biological data which we really didn't have a conceptual understanding of how could interneurons, which are thought to be inhibitory, in fact trigger a seizure or initiate a seizure. And so then this was work done by Scott, Francis, and Homaira, where in fact we demonstrate this dynamical property of inhibitory networks, and we think towards that we could use these types of insights towards building larger scale models. And this is where really we're, you know, very excited to be working with Jeremy, where, you know, we believe we can take you know, use biologically inspired mean field models to build to scale brain scale simulations, where in fact then we can try to understand how we can exploit the types of hardware that we're developing towards spatiotemporal control of the brain, but more specifically about how to perturb it away from the seizure state. I think I'll probably almost run out of time, but that's my large overview of the kind of work that we're doing here. Of course, a lot of all this work is really done by others and not myself. Thank you.
Thank you very much, Taufik. It was a great talk. So we have two questions, and if you can see the question, you can also go ahead if you wish, or I can read the question for you, but you can also see the question.
Okay, maybe we could read it. It'd be easier, maybe.
Okay, sure. Yeah. So the first question by Alexandra: what is the overall effectiveness of closed-loop stimulation versus deep brain stimulation for seizure treatments?
I mean, that's a great question. So I'll start with a really broad overview, or a really simple, is that there's probably no, we don't know yet. There's really no comparative data head to head. However, if you look at all neuromodulation technology, so if you look at the NeuroPace, if you look at the vagus nerve stimulator, and you look at anterior nucleus stimulation of the thalamus, which is deep brain stimulation for epilepsy, what you actually find is you find that about 70% of patients have a 50% or greater reduction in their seizures. So it's interesting that you have all these different kind of modalities, closed loop, non-closed loop, open loop, which is deep brain stimulation in the anterior nucleus. And you look at vagus nerve stimulation, which is not brain stimulation per se. It is closed loop in the sense that it senses heart rate as a proxy for seizure activity. And when you look across all of these, what you see is you have exactly the same responder rates. And if you look, in fact, at the literature on the NeuroPace system, what you realize is that, in fact, the proximity of the electrode to the actual seizure focus is not a determinant of its efficacy. And so a sort of a nihilistic view on this is that all of the devices currently that neuromodulate the brain, especially for epilepsy per se, do so in a non-specific fashion. And so stimulating the cortex, and as you saw with the data from the NeuroPace, that it generates approximately 2,000 false positives per day, up to 2,000 false positives per day. And again, I'm not maligning the device, just saying that, epilepsy is a difficult problem. And so what one can infer from that is that almost wherever you stimulate in the brain, that you're going to get about the same effect. And the question will be, well, why is that? And so, one could argue that, stimulating the brain anywhere in the brain, given its small world architecture, that you effectively stimulate many areas of the brain. And the way the brain generally responds to electrical or excitatory stimulation is basically to, down-regulate its excitability. So you could actually then think that, well, basically it's not specifically stopping a seizure when it thinks maybe a seizure starting. It's really just overall increasing the resiliency of that system to a seizure. So it's good at increasing the threshold of that system. So it's hard to actually then really say that, we can do a head-to-head comparison right now, because I think right now the devices, particularly from a closed loop perspective, are not really doing closed loop in a way. And then you say, well, well, that sounds very nihilistic. And yes, in some ways, I mean, as you know, control of a system really depends on what you can observe. And, one of the problems clinically is that we have such a limited area from which we can observe from, and rarely, if ever, will I be able to actually implant an electrode specifically, within the exact area where the seizure started. And we also know that the dynamics of each and every seizure for a patient can be different, on a different day. That sometimes it can be multifocal, which means that you may only have a subset of areas that are really truly generating seizures that which you have access to stimulate. And so there's kind of like this, and whether or not it's true, we don't know, which is this idea that scale will always help. And so as you can see, like, for example, in the Brain Initiative, where there's a lot of interest in scaling up the number of recording sites and the number of neurons, the hope is that, the more information we get in this way, potentially that'll not only be able to allow us to detect better, but potentially to be able to control the system, which of course I use control very sparingly, because there's a lot of literature to argue that the control is, the brain is weakly controllable, if at all controllable. So I think there's a lot still to be done.
Yeah, thank you. Tawfiq, we have another question. I think you actually responded, but anyways, I'll ask this question. Okay, so we have one more question actually, which is highly voted. I'm going to that. From an epileptic patient's perspective, how much reduction is clinically sufficient from a closed loop device?
Yeah, so I think that's really a great question. In fact, that reminds me of a meeting we're at, which was the old name for the meeting was Chaos in the Brain, but it became the Seizure Prediction and Control workshop. And they actually had individuals from the epilepsy community there, and it was a time when, in fact, the NeuroVista device had come out, which is actually a seizure warning system. And the system would provide a sort of an alarm or a light, a different colored light, depending on the likelihood of having a seizure within the next several hours. And the device was met with very mixed. It was received in a very mixed fashion, largely because patients felt that that kind of generic that you're going to have you're at a higher risk of having a seizure in the next 5 hours is actually very, very anxiety provoking for individuals. So, the idea of seizure prediction and warning is, a very difficult thing. And I think your question's, really great. We know from the surgical literature that in fact, the quality of life is almost like a step function in regards to their seizure frequency. So that's why our goal always, from a surgical point of view, is to render people seizure-free, because as soon as you have one seizure, your quality of life significantly plummets. And the reason being because the uncertainty or the fear of having another one, the unpredictability of epilepsy, which really generates and really affects quality of life, in addition to stigma. And so now that's kind of like the hard endpoint we really want to achieve, which is seizure freedom. However, you can't always do that. And so in individuals who are, having, say, 10 to 20, hundreds of seizures per day, if you can reduce their number of seizures, then that's a huge improvement in quality of life, although not approaching what it's like to be seizure-free, of course. And that also can have a huge benefit, too, to the caregivers, because then the caregivers are, of course, less worried about their, they don't have to tend to them as much. And then some of the neuromodulated devices, which is, for example, the vagus nerve stimulator, has some anecdotal benefits in respect to cognition, for example. So children, for example, are often thought, or it's often said that when they have the device, not only their seizure frequency may be reduced, but in fact, they may be more alert, more engaged. And so there may be added benefits of just reducing the seizure burden of the brain. And this kind of speaks to Wilder Penfield's term, which is called nociferous brain activity, which if you just overall reduce the abnormal paroxysmal activity within the brain, then maybe people are able to more engage within their environment.
That's great. Thank you so much, Tawfiq. We're on time. And if you had time, I mean, we have panel discussion, but it's not mandatory. If you had time, we can also have you there. But anyways, thank you so much for your time. It was a great pleasure to have you here.
Everybody. Bye.
Thank you. Bye.